Thanks very much. It's very good and healthy to come out into a community event. It's good for me to get out of the secondary care mode. So very much at the other end of the scale, as John said, and I thought Rosa's talk was very interesting and very specialised service that we have, and small numbers of younger people having to go to that service. And we are going to talk about the other extreme, where pain is almost endemic in the older population, and we can't have the luxury of having a specialised tertiary service to send all these people to. So it's something that you're all very much involved with, something that we can assist with in secondary care, and there are some referral pathways that are helpful. So I will describe what options there are, and I just want to talk about a lot of common scenarios that we face, because a lot of the time it isn't a case of a simple diagnosis and following a simple pathway. It's tailoring everything to the needs of the individual, and it's all a balancing act and understanding the complexities that individual faces and what their individual circumstances are. So quite a different approach. We've also gone down the line of referring to persistent pain. I think sometimes problems that children face are felt to be unacceptable, and they must be dealt with, and they must be dealt with appropriately. And sadly, when we look at the older age group, there's still a lot of ageism in our society, and we expect older people to put up with a lot of problems that we don't expect younger adults to put up with. So we've steered away from the word chronic, and we like to use the word persistent pain because we feel it puts more of a positive slant on them. So firstly, what is pain? I'm guessing you all know what pain is, but I think it is useful to reflect on what the definition of pain is. It's not just something that's easy for a patient to describe. It's a very unpleasant sensory and also an emotional experience, and in the group that we're talking about, that aspect is very important. It's a very, very complex phenomenon, and unless we take time to really assess people and understand that, then we can't manage it appropriately. It's derived from sensory stimuli or neurological injury, and it can be acute or persistent. And in older people, when we've got lots of different conditions happening at once, where they can have acute problems happening at the same time as chronic problems that have been a problem for years, or persistent problems I should say, we've really got to get into the detail to really understand how we're going to solve this. I quite like this definition. It's a subjective personal experience described at different levels. You've got the sensory that the patient can describe to you. We can talk about the intensity of pain, we can talk about the location of pain, and then there's the affective side. How's that affecting them emotionally? Often when it's a persistent problem, it does get them down a lot, and we have to deal with that aspect. And then there's the impact, the disabling effects. So if you have a pain and you already have other problems with your mobility, if that's going to impact on your function, then it could mean you're not getting out and about, you're not able to do things for yourself. It can result in institutionalisation, increase your dependency, and you can really get stuck in a very difficult situation if you don't intervene. So what's important for GPs and others working in primary care? Well, it's under-recognised and it's under-treated, and I think that's no longer acceptable. This is something that we have to tackle. Demographics are changing. You will be aware there are rising numbers of older people, and that is just going to continue. And I think we're not really ready for that challenge, and we have to try and tackle this. You'll be aware of Reshaping Care, the government's agenda to shift the focus of care into the community, which is appropriate if there are services there to support it. So I think this is something that you're only going to see more and more of in the future. It's a frequent reason for patients consulting GPs and other community professionals. There's a huge prescribing burden associated with this. Older people are often taking many medications. It's not unusual for us to see people coming into hospital on more than a dozen medications, and fairly common for 2 or 3 analgesics to be in there amongst it, some of which they may be taking, some of which they're not taking. So a huge cost element and a huge responsibility for you to monitor that and make sure prescribing is appropriate. And then there are other consequences of polypharmacy. We know there's an associated risk of falling, which is probably because it's a marker of comorbidity. If you've got lots of other diseases, you're more likely to be on lots of medication. There's huge issues with falls if you're on antidepressant drugs, any drug that affects your central nervous system, antihypertensives, and falling can just result in so many problems for older people. It can cause delirium. another reason for people being admitted to hospital. Older people are more likely to experience adverse drug reactions, and the more medicines they take, the more likely you are to experience an adverse drug reaction, and you can get caught in a problem of prescribing one drug to counteract the effects of another. So it's a massive problem. It's also often a cause of complaint when we don't get it right, and we see this a lot in hospital, particularly towards the end of life, or if someone's been deteriorating and relatives feel the person they've been attending to has not had a good death, or just not had a good experience in hospital, or perhaps staff have been too busy to give them analgesia, or we haven't recognised the problem. And that's very distressing, and something that we've been trying to tackle. I think the issue of information sharing with community staff is very important as well. I think any event you go to now with secondary care, it's discussed how we can all communicate better and what the interface will be, and I look forward to the electronic age when this is all going to happen, because I'm told it will happen, so it must be true. But I think there's responsibilities on both sides there. If we're making changes to medication in hospital, we should be telling staff in primary care of what's happened, and actually before we make a change, if someone's been on a particular regime, then we've got a responsibility to check why they're on that regime, what's been happening. So I think it works both ways. We both get that responsibility. So why does it matter so much? Well, it's just very common. Depends which study you read, but estimates are between 25 and 50% of community dwelling people experiencing pain. If you look at people in nursing homes, then that number rises to up to 80%, depending on which study you read. So you can see why we don't need a tertiary referral centre. We'd be seeing absolutely everybody, so it's something that generalists need to be good at. And the causes of the pain are multiple, particularly in older people. We see a lot of arthritis, we see peripheral vascular disease, we see all kinds of neuropathies, people have acute osteoporotic fractures, and then there's the whole cancer pain issue as well. As in other age groups, we can divide it into different categories: nociceptive, neuropathic, mixed and psychological. So nociceptive, we're referring to visceral or somatic pain, which is derived from stimulation of pain receptors. I'm not going to show you a complex flowchart, given that it's an anaesthetist in the audience. I don't want to get into that, talking about receptors. But basically this kind of pain can result from inflammation, injury, destruction, deformity, and it's important to remember all of that when we're carrying out our assessment. We have to think about arthritis, ischemic disorders, and this type of pain tends to respond well to conventional analgesics, opioids and non-steroidals. Neuropathic can be a bit more complex, particularly when you're trying to get a good description of pain from someone who's got cognitive impairment. So we do have to take quite a lot of time in trying to understand about the pain. So it can involve peripheral or central nervous system. We see a lot of people post-stroke who have neuropathic pain, a lot of people with diabetic neuropathy, phantom limb pain if they've had an amputation. And that tends to respond less well to conventional analgesics, but there are a considerable number of options available, which we'll go on to talk about. So we do have to ask specifically about shooting pain, burning, dysesthesia. We have to be very careful that we get a good description, and sometimes we have to involve relatives as well in that. What have they observed? Because the patient themselves might not be able to tell us, so observation is very important. And often it's mixed. We get a bit of arthritis, we get a bit of neuropathy, so it can be really very difficult to try and understand exactly what's going on, and often you have to try a number of different approaches. You might have to try combinations of drugs and be very careful about the side effects. We do also see psychological causes, as we discussed, happens in children, and sometimes we do have to refer on for psychiatric treatment to try and help with that and not just stick with simple analgesics. So the impact of persistent pain, I mentioned earlier, physical function, and that's of major importance, because if people have gone from being mobile and able to live alone and carry out all activities of daily living, having some episode of pain can disrupt all of that. So they could go to requiring care support, they may need to be hospitalised because they can't get themselves up, and then it just can spiral on from there. You'll have seen patients deteriorate in that kind of situation. So the impacts of that are massive. But it can also cause sleep disturbance, can result in anorexia, which for older people who are already nutritionally challenged, that can be a problem. It can also be a cause of delirium, which is very important to remember, particularly if you're seeing someone who's got dementia and perhaps can't communicate with you. I saw somebody recently in the medical assessment unit who didn't seem to be getting a great deal of attention from the staff, and it looked like they'd had a difficult shift because this patient had been very agitated. The staff didn't really know what to do, and she was referred to us, and we went to see her, had to kind of spend a bit of time just calming her down and just chatting. And actually the one thing she said was, "I've got a really sore back," and nobody had picked up on that. And what a shame. She'd been in for 24 hours, she'd been through all the assessments, been seen all these qualified doctors and other staff, and it took 2 people to sit down with her for 5 minutes to establish what the cause of the problem was. And she'd been refusing analgesia, it was noted, uncooperative, refusing analgesia, and we went back and gave her the medication, and she took it without any problem. She said, "Thank you for being so nice." So sadly, we do have to come down to a really basic level, and I just think that's totally inadequate, that's the situation we're in, but there we are, we're trying to do something about it. Anxiety and depression are a common problem as well. People worry about why they're in pain, and often, perhaps if you're of an advanced age, you do worry about the impact of what it means. Perhaps it means I've got an underlying problem, I don't really want to have lots of tests, I don't want to talk about it. If I'm not managing, I'll be put into a care home. All of these things are a really big issue. And just dealing with pain on a day-to-day basis can really wear you down, and it often does cause depression. And then that can impair your social function. If you're not physically functioning and your mood's low, then that affects your social function, and it's bad for older people to be isolated. So there's a big impact on recovery. We see a lot of patients following hip fracture, and I think the support they get initially after the operation is fantastic. There's very good anaesthetic support and acute pain support. And then further down the line, there's an expectation that they'll be managing better, and they'll get up and they'll be mobile and they'll be discharged home very quickly. And at this point, we're often involved, and we see a lot of people who don't really have adequate pain management, and we're trying to address that. And that can be a barrier to rehabilitation, because sadly patients can be seen as being a wee bit uncooperative if people don't understand what the issue is. Perhaps, she refused to come round for physiotherapy. Well, did anybody ask her why? Did anybody go and spend 10 minutes talking to her and understand that she's been sore all night, she's not had a good sleep, and she's in agony, and actually all she wants to do is lie in bed and get some painkillers? So, it's really changing the culture to understand what the issues are. But if we don't tackle that, then it increases the length of stay in hospital, and perhaps they might not have such a good outcome as they may have had if we'd addressed it early on, and it can reduce quality of life. So there's been quite a lot of work done in assessing pain in older people, and there are some national guidelines. This is a very good booklet. I've included a web reference there, and there's a reference at the end of the talk. It's quite a simple wee booklet to have a look at. It particularly talks about assessment of pain. It's a joint statement by the Royal College of Physicians, the British Geriatric Society and the British Pain Society. And one of the problems is there's not really one universally agreed way to assess pain in older people, because it is so complex. The main advice is that you do consider it, and you take some time to assess the patient. Using rating scales can be complex in older people. If they do have visual problems or manual dexterity problems or communication problems, it can be difficult to assess that on a scale of 1 to 10. Older people tend to cope better with vertical rating scales and very simple scoring scales. So usually trying a variety of these works for patients, and it's whatever you can get to work for the individual is okay. The simpler the better. And just recording response to analgesia is very important as well, which is something I don't think we do often enough. We're quite good at just giving something and saying come back and let us know if it doesn't work, but I think we need to be a bit more proactive in trying to make sure that it has been effective. And recently in Glasgow, but really following on from a couple of complaints that had come in about how pain was being managed, we tried to incorporate some of this evidence into our practice. And after quite a detailed search of the literature, we came up with our own generic pain tool, which basically is a sheet with a combination of different vertical rating scales, a body map and a numerical scale. And really what we ask to happen now for every patient over 65 is that they have this regular assessment. We initially tried to introduce it as happening on a daily basis in the acute wards, which is really quite challenging given the amount of paperwork that we now ask our nursing staff to complete. But when we first introduced this, it wasn't actually something that was in the basic care plan, which is quite incredible. We're seeing up to 80% of older people may have this problem when they come in, and we ask about, you know, pages and pages of questions on a whole load of other issues, but we don't ask about pain. So that has now been changed, and there's now a modified care plan, and there is an agreed generic pain assessment tool that's in use. So that's been very good, but it only really works if the rest of the staff follow it up and pay attention to what the records are showing and take action if there is a problem. We've also used something called a PAC/SLAC, which I still forget what it stands for, so I have to always look at this sheet. It's called the Pain Assessment Checklist for Seniors with Limited Ability to Communicate. And the reason we chose this tool is that there are some other tools that you may have come across, those of you who work in nursing home practices or continuing care wards. They often use the Abbey Pain Scale, which is quite good and quite simple. And that's one that is recommended in this guidance. The PAC/SLAC was one that we felt had a bit more detail, which we felt was more appropriate for the groups of patients we were seeing in hospital. But basically it's a checklist that's done on one page, and they look at different domains. So if someone can't really communicate their pain, then we should rely on what we observe. So we can look at facial expressions. Do they look sad? Are they grimacing? Has there been a change in their eyes? Are they clenching their teeth? What's their body movement like? Are they fidgety? Are they restless? Or have they gone from being restless to then being still? Sometimes that's relevant. And what's their social interaction like? Have they become aggressive, or are they withdrawing from people? So that can be really quite helpful if it's completed by someone who really knows the individual, and it's also relevant if there's been a change. So it can be quite helpful to do this, particularly in continuing care wards. We've got a lot of frail older people who may be in for several weeks at a time, and relatives can complete this, or nursing staff that know them well can complete this. And then if there's been a change, then it's highlighted to medical staff, and it indicates that we might need to review the analgesia that they're on. But in order to achieve this, we had to really have quite a massive educational campaign to get a change in practice, and we were very grateful to colleagues in palliative care practice development who did a lot of education sessions with nurses. But I think it went down very well, because most people working with older people felt that they didn't really have the skills to do this properly. So I think it's been hugely beneficial. If we'll go on and look at treatment, so if we've done this great assessment and we've identified exactly what the pain is and what the components are, then we have some responsibility to then try and offer some treatment. The evidence base is quite limited, like a lot of conditions that affect older people, because you tend not to get trials specifically looking at a lot of issues in older people. It's improving as time goes on. There are some references I've included at the end of the talk that appeared in the Journal of the American Geriatric Society that give a really good overview of use of different analgesics and what the evidence is to support it. So I'm not going to run through that just now, but you can look at the evidence base yourself. And certainly there's been, I think, a lot of reluctance to use stronger opioids. A lot of people have veered away from giving morphine, but one of the things that comes out of this guidance is that people shouldn't be denied access to these drugs. If they are good painkillers, then we should be aiming for people not to be in pain. And overall, that is the most important thing. And we'll talk about in a bit more detail some of the other drugs. So we do have to be careful about side effects, but we should make sure people still have access and are considered. All these treatments that are available to adults in middle age. And some of the trial evidence suggests that the neurocognitive problems are not any worse for older people than they are in middle-aged adults. So I think more evidence will come with time. We still use the World Health Organization analgesic ladder. It's still appropriate. So we do start off with paracetamol. We do still consider non-steroidals. We do have to be careful about peptic ulceration, about renal function, which are both more common as you get older. But if you use them with gastric protection, they can be well tolerated, particularly if they're used for a short period of time and you keep it under review. And then we do use weak opioids for mild to moderate pain, codeine, tramadol, etc. There can be difficulties with these drugs, particularly the neurocognitive side effects can be problematic, and it does need careful consideration, and the most important thing is just to review with the patient in front of you to see how they're reacting to that drug, what the response has been. A lot of geriatricians dislike tramadol. We do see patients developing hallucinations, so it's probably something that we don't often introduce, but we see a lot of people coming in from primary care on tramadol, so we wouldn't automatically stop it, but it is one of the drugs we would carefully think about when we do a medication review. And for some people who can't tolerate the side effects of the weak opioids, we may move quite quickly onto morphine. And morphine at a low dose can be very well tolerated. We see a lot of people getting very constipated on codeine. So if they're getting constipated, they're confused, sometimes just considering, a switch. A trial of low-dose Oromorph at 2.5 milligrams, see how they respond, and then you might quickly go on to MST 5 milligrams BD, and a lot of older people tolerate that very well. Giving PRN analgesia can be very problematic in older people. If we've got a group that tend not to want to complain, there's perhaps an acceptance that this is just a normal part of ageing. Well, what do I expect at my age? I'm bound to have some aches and pains. They often don't volunteer that they're in pain. So that can be a problem, and I guess if you're using it in primary care, if you've got someone who's a bit confused, a bit difficult to kind of send them home with a bottle of morphine by their bed and say, just take 2.5 mils. So often, coming up with a regime that's done regularly, perhaps using dose set boxes, etc. We have to think about all of that, how we're actually practically going to supervise the medication. So, World Health Organization ladder still appropriate. Very useful to make one change at a time as well. If we've got people that are on a dozen medications, if we then say, well, we'll try non-steroidal and a bit of opiate, well, how are you going to know what's worked? And then if we've had a side effect, how do you know which one's caused the problem? So very helpful to do one change at a time and review it. And start low, go slow is good general advice when you're prescribing for older people. Don't go for a big whack straight away. Observe closely for side effects, talk to the patient, talk to the carers if appropriate, and it's just this constant reassessment and adjustment that's required. We also see a lot of people who've been on analgesics for a number of years, and then they come into hospital with another problem, perhaps have started falling, and they've been on drugs for 4 or 5 years, and we then have to reassess, well, okay, let's go back to basics. What are the problems? Which of these drugs are benefiting you? What's the evidence that we're giving you any benefit? So I think, very important to do these medication reviews, which I think is now happening much more frequently in primary care. And I think if it's all getting too complex, then there is specialist advice available. And I think as a geriatrician, it's something that we're very happy to provide support with. We do refer on to our colleagues in the pain service. So I guess it depends on the type of problem. If you've got an older person who has lots of different problems, mobility issues, a bit of heart failure, a bit of Parkinson's, and it's all about the whole interaction, then assessment by a geriatrician would be ideal. If it's a more single identifiable problem purely related to pain, then referral on to pain management might be more appropriate. So I've covered some of this already, but yes, they may think it's an unavoidable part of ageing, so people can often minimise it, or they just might not tell anyone about it at all, and you only realise it's a problem when you're observing them yourself. So there can be a reluctance to take analgesia. There's still a lot of stigma attached to drugs like morphine, or if you mention antidepressant type medication, there's often a stigma attached to that as well. But I think health professionals can also be guilty. Well, why should I, what am I going to change? She's had this pain for 10 years, what's the point in interfering now? Well, hopefully I'll convince you that there is a point. Pain that's persistent is most likely to be due to musculoskeletal disorders, but the other comorbidities are important to consider. The more specific pharmacological changes that we see with ageing, we see slowing of GI transit time, there's an increased fat to lean body weight ratio, liver metabolism and renal excretion may be reduced. Certainly you have reduced hepatic blood flow, reduced liver mass, and anticholinergic side effects are enhanced by neurological disease processes, so people that have had a history of stroke disease might not cope well with anticholinergics if they've got pre-existing cognitive impairment. So lots of things to consider. Okay, so we spoke a bit about paracetamol, non-steroidals and the mild opioids. Morphine would still be our first line if we were using a stronger opioid. Oxycodone, although it can have some benefits, can still cause problems in older people and it's more expensive. So we would generally go for a trial of Oromorph and then on to MST. And if that's not tolerated, we would then move on to oxycodone. We do use adjuvants. Tricyclics can be considered. Again, we're a bit resistant to starting drugs like amitriptyline. For neuropathic pain, the local guidelines are very comprehensive, and we use more gabapentin, I would say, than some of the other drugs like amitriptyline. But it's what your patient can tolerate. And obviously occasionally, depending on the condition, other preparations might be appropriate. Topical lidocaine can be very well tolerated, strictly used off licence in some situations, but very good for a lot of our patients, particularly if swallowing is a problem as well. We have to think about other routes of administration. So just a wee reminder of the potency. John was telling me at the start of this evening that there's going to be a kind of Ready Reckoner app that we'll be able to use soon to look at potency for all these drugs, which is great because it does get very confusing. Even if we're using these a lot, you do forget how strong one is compared to the other. So it's just good to be reminded when we're switching between these drugs, you know, working out what the transition should be. Buprenorphine we were using quite a lot, but you know, we've now been asked not to use that, although I know it's still in use a lot in primary care. It is very expensive. And this was actually quite good as a halfway house for a lot of people with persistent pain who perhaps had swallowing difficulties or compliance issues. But we're not able to prescribe this in hospital now unless it's been started in the community and we're continuing it, but it has to be under special licence. Fentanyl is also useful, but for a lot of our patients it's just such a big jump because it's equivalent to nearly 40 milligrams of oral morphine, so if that's the lowest dose of the patch for some of our patients, that's just too much. But a very good drug for patients with renal impairment, and if compliance or swallowing is an issue, it's very helpful to give it in a patch. Just a bit more about the other drugs. I mentioned tramadol. Gabapentin we use a lot, and it often is very well tolerated for neuropathic pain, but I would suggest that you start at 100 milligrams at night and not 300 as is often recommended, and just titrate it very carefully. So some people will have problems initially, but it can be a very good drug. We've also had good response to pregabalin, which is second line but very well tolerated and has a very good side effect profile in the elderly. There's also been a lot of debate about reducing paracetamol dose for patients whose weight's under 50 kilograms. I don't know what you feel about that in primary care. We can maybe discuss that at the end. I think a lot of this alarm happened when we were using IV paracetamol, and then there were some case reports of hepatotoxicity where patients ran into problems when they were below 50 kilograms. So generally a lot of people are now prescribing at half dose in frail older people whose weight's low, but you could probably debate whether that's evidence-based or not. I think the other trick that we sometimes find helpful if you've got somebody with neuropathic pain and you're perhaps titrating up gabapentin, sometimes the titration can be quite long and you've got a patient in front of you who's actually quite sore, and sometimes giving them an opioid initially, if they're responding to that, can be quite helpful while you introduce something like gabapentin, and then reviewing over time and then perhaps reducing the opioid. Sometimes that is quite a good strategy for some patients. Alternative routes, we have a lot of people who can't take medication or can't reliably take it regularly. And we have to think about patients with nasogastric tubes or PEG tubes who have to take different preparations or liquid preparations. And we have to think about transdermal routes and syringe drivers, usually at the end of life, but there are some patients in care homes or NHS continuing care wards who might use syringe drivers for a shorter period of time, particularly if you're trying to get on top of a problem in the acute situation. Okay, and then I thought I would just talk through some typical scenarios. I've got about half a dozen patients just to mention. They are very typical and they are based on real. There's no patient identifiable information, but they just demonstrate the kind of problems that we come across on a daily basis. So the first one's a 75-year-old lady who had mild cognitive impairment and came in through the front door, had falls, fractures excluded. She had a past medical history of osteoarthritis and transferred to the geriatric unit. And on the first review, people were saying, yeah, she's not doing so well as we thought. She was independently mobile before, but she's really struggling, and just from what people have been saying, we're just wondering if she's actually going to progress. She's probably going to need quite a long period of rehabilitation. Looks like she might not be able to return home. And then when you look into it in a bit more detail, you find that, yeah, she has been complaining of back pain, and nobody's really picked up on this, hasn't really been addressed, and it's really the physiotherapist that's picked up on that. It's been observed behaviour when she's been in the gym. And up until this point, she's been taking regular paracetamol and codeine, PRN. When you go and talk to the patient, she's been in pain. She's been refusing codeine because she feels it's not of any benefit and makes her constipated. But sometimes this is presented as though patients refuse, so it's assumed that pain is not an issue. So after some discussion, changed the analgesia, gave her a trial of Oromorph, which she tolerated, and then switched to MSTBD with a laxative. We'd always give it with a laxative. And then we gave her some PRN breakthrough morphine for when she was having her physio sessions, which can be quite helpful as well if you can predict that there's going to be episodes when patients are going to be sore. Perhaps if you've got someone in a care home and patients are sore when nurses are working with them, then sometimes prescribing analgesia before that intervention can be really helpful. And then just with these simple measures, and then she began to work better with rehabilitation, made progress, confidence is better, and returned home. So sometimes just being able to identify it and discuss it does make people a lot more confident. The next one's an 80-year-old man who was living alone, and his wife of 60 years had died, sadly, 3 months before he came into hospital. And he came in with falls, he had osteoarthritis, he'd had a previous left hip replacement, and he had diabetic peripheral neuropathy. And he was just observed as being very quiet and withdrawn, wasn't doing particularly well. Again, wee bit slow to rehabilitate, which is often just a sign that there's something else that we've not picked up. So you have to do a bit of investigating as to what's going on. And then on discussion with him, he did say he had some thigh pain, didn't really want to talk about it, didn't really want to bother anyone. But again, it was other staff working with him that had highlighted it, so we were able to go and discuss it. And he went on to have other investigations, did a number of things. I think he had an isotope bone scan in addition to basic x-rays, but the conclusion was it was osteoarthritis of his hip and knee. And he responded to a weak opioid, but further exploration of his low mood, he was actually feeling very depressed since his wife had died, and that the pain was impacting on his mood, and his mood was impacting on his ability to function. And he actually responded really well. We gave him a combination of a weak opioid and an SSRI, and he did very well and returned home with support. The next one's a 79-year-old lady who came into the orthopaedic unit with a pubic ramus fracture initially, and she was transferred to our service for rehabilitation. And she was in a lot of pain, really severe pelvic pain despite codeine regularly. And then took time to investigate what was going on. Turned out she was very severely constipated. I think bowels hadn't moved for about a week, and nobody really picked up on that. She also reported some neuropathic features to her pain, and just absolutely, utterly miserable, completely withdrawn. So we investigated further, and she had a bone scan which showed metastatic bone disease, which could easily have been missed if we hadn't really taken time to assess it further. She didn't tolerate morphine very well. She just became very drowsy and flat, so we had to make other adjustments. So we did actually get her very comfortable, but in order to achieve that, we had to switch her opioid onto oxycodone. We ended up giving her ibuprofen as well for her bony pain. We added in some gabapentin because she had neuropathic element. She went for radiotherapy, and the constipation was actually quite painful for her as well. And she needed quite a lot of psychological support because she'd just been diagnosed with metastatic disease as well. So really, one simple strategy and one drug would not have worked for this lady. It's the real combined approach, as those of you that work in palliative care will appreciate as well. So they were all inpatients. There's a few more that I saw in the outpatient clinic that I thought were quite good to highlight. This was an interesting couple. This kind of cheered me up on a Tuesday morning. It's an 81-year-old lady come in with her husband, and her husband was incredibly talkative and wanted to tell me everything about their life and took charge of the consultation. And he was concerned. He said, you know, she just won't let me to be close to her any longer. I can't sit with her even if I go and put my hand on her knee. She's withdrawn. And the wife was absolutely mortified that he was discussing all of this in a clinic. So we found a way to get him out of the room. And when I actually spoke to her alone, she was just utterly miserable, actually, not sleeping well, described neuropathic pain. She'd had a history of spinal stenosis, but it hadn't really been causing her such significant problems until recently. And very much playing down with, oh no, you know, it's not a big deal, you know, playing down what her husband was said. So convinced her to try and take something to try and address the pain, because I could see it was causing a lot of distress, and she started on a trial of gabapentin. I don't think she initially believed that that was actually going to work and going to solve the problem. And she came back a few weeks later. It had been carefully titrated by her GP, very good response to analgesia, pain was better, she was sleeping better, she looked a lot brighter, and her husband was delighted. So I didn't get into the ins and outs of that, but I'm comfortable with that as a geriatrician. So the next one's a 93-year-old lady who I just saw last week. So she was referred to me for another reason. She was referred for consideration of IV bisphosphonate, which we're giving for osteoporosis for some patients. She was very kyphotic, very poor mobility coming into the room, a very high risk of falling. And she really didn't want to disclose very much. She said, yeah, she's very well, it's all fine, she'll take the treatment for osteoporosis, no problems. But she was a bit cognitively impaired, and I felt I had to treat her under the Adults with Incapacity Act, so I phoned her next of kin, and she said, oh, it's been an utter disaster, she's in a lot of pain, she's often crying at night, you know, I go down to see her and she's just completely miserable, and the patient didn't tell me any of this. And she was taking paracetamol and dihydrocodeine, taking them both regularly, but it wasn't really solving the problem. So in that situation, you know, she seemed to be partly opioid responsive, so we decided to give her a trial of MST 5 milligrams BD, and thought there's scope to increase that if necessary. It's not such a big jump from the codeine, but easier to titrate in the community. And I think giving her PRN analgesia just wouldn't have worked. There's no way I could have had reassurance that that was going to be a safe way of giving her medication. And time will tell if that's effective, but just quite striking that someone can come into the room, you've no idea that that's going to be the underlying issue. People don't report it. And the last one's a 79-year-old lady with a history of breast cancer. This lady's in my ward at the moment. Falls, hallucinations, poor mobility, cognitive impairment, and then this possible underlying lung cancer on a CT thorax 3 months before. And the main concern for us was how she was functioning. Would she get back home? Mobility wasn't good, high falls risk, can she cope on her own? And it was really her relatives, when they came to talk about her future care, said, you know, when we come in every day, she's telling us she's got chest wall pain, and she hadn't really described that to us. She reported it to staff once, and she got given a weak opioid, and we thought that was all fine. And then one day she became acutely unwell with breathlessness, and she had a CTP carried out to look for pulmonary embolism, and that was negative, but we did see progression of lung lesions, and she developed some new rib fractures despite a recent bone scan being normal. So we're giving her a stronger opioid and non-steroidal with careful monitoring of renal function, and she's also got a lidocaine plaster added in as well, and she's much more comfortable with that regime. So just to kind of review which of this is most relevant to you in general practice, well, feel free to tell me at the end what's relevant to you. But I think good for you to have an awareness of the current evidence, which is limited, but there's enough evidence to suggest that older people should receive a trial of appropriate medication, and good for you to know what the useful approaches are. I think applying this to a 7-minute consultation is pretty challenging. I don't think I could do a lot of this in 7 minutes. But I think remember the option of referral to the pain clinic or to the day hospitals. We're doing a wee bit of promotion around the city at the moment about use of day hospitals. We feel they're underused. Ideal for people with multidisciplinary problems who need further assessment. And there's a day hospital near you that will be happy to receive such referrals, so please remember. The role of the community geriatrician is being looked at around the city. There are individuals that have sessions for community support. That's done in various different ways around the city. A lot of geriatricians are liaising with local community rehabilitation teams. And I think given the reshaping care agenda, that's only going to increase. So again, it's another way of supporting patients in primary care in the community. So hopefully that will improve as time goes on and will give you a useful resource. I think I would encourage some follow-up of patients discharged from hospital and review of analgesia as well, particularly if we've had somebody in with a hip fracture, we've established them an opioid, they've gone home, 3 months down the line they've returned to normal activities. I guess we're not routinely seeing these people back. And I think it is useful if some sort of follow-up of medication review is in place. And I think remember that pain can be a cause of agitation in patients with dementia. Because often people can be fired into hospital, it's assumed to be sepsis, and just remembering that pain is another cause for agitation, particularly in the nursing home group as well. So it's a very complex phenomenon, many potential causes in older people. Persistent pain is very common, might go unreported, and I think just effective management needs to be part of our routine practice if we want to achieve good outcomes for these patients. The guidelines tell us any health assessment should identify the presence of pain. I appreciate not always possible in the community if you're seeing a patient for another reason, but I think if you're doing a detailed assessment, it's an opportunity that we can take. It can be complex and needs detailed history and examination. Consider communication difficulties and cognitive impairment and how you're going to carry out an assessment in that situation. And we should really be recording intensity of pain and the response to treatment. And that's just what I'd recommend you to read. So the assessment guidelines and the 2 references from the Journal of the American Geriatric Society looking at management of persistent pain that give an overview of the different categories of drugs as well and what trial evidence there is to support use of each of these. And then also we've got very good Glasgow guidelines as well.